Just before we move on to another round table, I have some AirPods that have been lost. So if these are your AirPods and they do have initials on, please let me know and I will reunite them with you. So now we're ready for our next roundtable, this time on the advancement in obesity management. So to introduce this session, please welcome Anne Moore, who's the principal of Roland Berger. And we are also being joined partly by live guests with us and partly by remote guests as well. So we have Maite Tauber, who's a pediatric endocrinologist at CHU de Toulouse. We have Isabelle Longeon-Domenech, VP Clinical, Medical and Regulatory Affairs in France for Novo Nordisk. And Igor Grandin, founder, CEO and chairman of Calitech. Oh, and Reginald Alouche, founder and CEO of Paltech. Anne, I will leave you to your roundtable with your live and remote guests.
Yeah, that's a trial for us today, so bear with us, please. Can we try and have our friends on the screen, maybe? Okay, so we will try maybe to start with that. So we will have an hybrid session, so please bear with us, and it might not be as interactive as we want. So yeah, we have everyone now on the screen. Thank you very much for coming for our roundtable today. I will just leave the floor. We'll try to be as interactive as we can, but yet again, being in an hybrid mode, it might be a little bit difficult, so bear with us for that as well. I will leave the floor for everyone to get introduced. It's my real pleasure to be discussing for obesity today. I think it's a very interesting field to be in. We've seen a lot of different innovation. I think we were not talking about obesity the right way in the past, or at least not the way we are doing it today. Obesity is coming from a very socially burdened, heavy burden type of disease where people were not taking care of themselves, not doing any diet, not doing any lifestyle changes so that they would get obese, and that was partly because of them. Now we are more talking about that being a disease and coming up with a way of handling the patient and helping them. And I think it's a real breakthrough in the disease. That's also how we came up with such fantastic drugs such as GLP-1 and the others. I think we also have to keep in mind the other disease that we are going to talk about, such as a NASH, such as the obesity being as a hereditary disease, which is also something quite complex to deal with, to try and find those patients and help them, again, bringing the drugs for them. And with that, I will leave the floor to let my colleagues present themselves. Isabelle, do you want to start?
Yes. Good afternoon, everyone. Isabelle Longeon-Domenech. I'm the medical director for Novo Nordisk in France.
I'm Reginald Alouche. I am the CEO of Paltech France.
Maite online? Can you try and fix the sound? Sorry, Maite, we cannot hear you yet. Can you try again? She's not on mute. I know someone is asking. It's not the usual issue of being on mute. Igor, can you try maybe?
Let's try. Can you hear me?
Yeah, that's working, yeah.
So good afternoon. Thank you for this beautiful conference. Unfortunately, I was not able to be there physically. My name is Gindin Igor. I'm Calitech CEO and founder. Calitech is a startup that tries to deal with obesity.
Maite? It's not working, Maite. Maybe while, so Maite is actually joining from the CHU de Toulouse. Do you want Reginald to take over maybe for now? So while Maite is trying to connect, I think the important thing for us is to try and understand and make sure we are all talking about the same thing when we're talking about obesity. So maybe Reginald, you can give a brief overview about obesity. And
yes, I could talk about obesity. Obesity is a disease. It's not something that you're not. It's a real disease with inflammatory process. And a lot of people, I am not going to give numbers, you know that in the United States, in China also, in Europe, Obesity is climbing and is increasing every day. So it's something that we have to handle, because if we don't handle that, we will have a lot of disease linked with obesity. The first one is diabetes, type 2 diabetes. As you know, type 2 diabetes, a huge number of people are diabetics in the world. But more fearing for me is that we have probably around 1 billion of pre-diabetics. And 70% of those people will be diabetics in the 10 next years. So I think that the problem is that we have difficulties and problem to handle and to cure the people now, but we have a big stock, big numbers of people coming, and it will be for each and every country, it will be a real health problem. And there is treatment, there is therapy, we will have to discuss of that. And in my company, we have a pathway with a medical device to cure, to have a remission of type 2 diabetes. And I'm sure there is a lot of solution in the field that are coming. And but the big success today are the GLP-1 treatment. You know that GLP-1. I went to Madrid. It was the ASD, I mean the Congress for Diabetics, for diabetes, and it was like a big party for GLP-1. GLP-1 everywhere, communication around the GLP-1, but you have also something very interesting about the CGM, all the captors you see for the glucose. And again, if we want to fight against diabetes, against obesity, we need some tools for prevention too. So I think prevention is the key. And I'm sure that a lot of products, of device, we'll have with Igor an example, will help people to fight obesity and, of course, diabetes, because a lot of obese people are diabetics.
Thank you, Reginald. I think when we were preparing the roundtable, that was quite interesting also to have the discussion around obesity. So as you said, obesity, diabetes, all are diseases that we kind of know all around the table. But maybe, Isabelle, you have some more information to help us better understand the underlying causes and the complication and how to handle obesity as a whole, and not that being just a weight issue or a diabetic issue, but help us understand the whole disease.
And maybe because we are in France today, in Paris, I think it's important maybe to share the latest number regarding the epidemiology of overweight and obesity in France. Half of the population, the French population, has overweight, and nearly 18% has obesity. And we know that this is increasing, like in other countries in the world. And we thought initially that this excess of fat would not necessarily mean a lot of complication for the patient, but that's not true. We have seen that this excess of fat tissue, in fact, is not inactive. It generates a lot of inflammatory component that creates, for example, cardiovascular disease. So those patients are more likely to develop myocardial infection or stroke, also death from cardiovascular disease. And in fact, patients that are obese are more likely to die from cardiovascular disease after 50 years of age. So we know, and it has been said also previously, that this is a chronic disease. It's not only being with excess fat, it's a chronic disease. And this disease can also lead to cardiovascular complication, but also to cancer. And nearly 14 cancers have been described related to obesity. And why do we have this epidemic of obesity? And it's multifactorial. Of course, it's linked to nutrition, it's linked to sedentarity, less exercise, but it's also, there are psychosocial components. There have been people who have suffered in their childhood who can develop later on obesity. It's also genetic, and Maite hopefully can share a bit more about that. So it's really a complex disease that has been also associated with stigma for quite some time, which has prevented people to be treated or managed appropriately, like other chronic disease. And it's very important now that we realize that those people are really suffering, have life expectancy that is affected, so that we can find solution from them.
Maite, do you have any information on the epigenetic part of the disease? Is this working? It's not working. We cannot hear you. Maybe Regina.
I would like to emphasize something that you said about chronic inflammation, low-grade inflammation. I mean, low-grade inflammation is probably the mother of disease. And this low-grade inflammation is provoked by the adipocytes. As you know, the adipocytes are the cells that are storing the fat coming from sugar or from fat. And this adipocyte, when they are full, they are emitting what we call cytokines, I mean hormones, inflammatory hormone, at a very low level, but every day, every minute. And when you do so, the immune system is always awake, and at one time it will stop to be efficient. You see, and this obesity is, as you said, is not only fat; it's inflammatory chronic disease, and you have also all other diseases like arthrosis, for example, linked to inflammation. You could have also problem with your bones, your problem with articulation, your problem. It's an obese person. Sometimes you see you have people saying, yes. Obese people could be happy. You know that. You know that story. In fact, when you are a doctor and you are talking with patients, you see that at the end of the day that it's a very, very hard disease to live to the day to day.
I'm sorry, perhaps it's working now?
Ah, right.
We cannot see you, we can hear
Great.
you.
Welcome.
Thank you. I'm sorry. So about epigenetic perhaps, or genetic causes?
If you can just maybe introduce yourself real quick, Maite, so we know
yes.
You're coming from.
I thought it has been done already. So I am a pediatrician. I'm an expert in endocrinology and particularly in obesity. And I'm working on obesity, focusing in rare causes of obesity since 20 years. Yes, I've been particularly in Prader-Willi syndrome, which is one model of syndromic obesity. So what we have learned from rare causes, rare genetic causes of obesity is that it is an impairment of the leptin-melanocortin pathways that regulates homeostasis and energy and metabolism with endocrine function. But it's also very well connected with the dopaminergic system, which is a reward system, which is very important in obesity. And it was also connected with the frontal cortex, which is a decision making. So it has been said that it's not only obesity, it's not linked with people who don't do what they have to do. It's a real disease, and particularly a disease that drives abnormal behavior, abnormal feeding behavior. It's not voluntary, it's a disorder. And just a word for epigenetic. Even in those genetic causes of obesity, we know now that epigenetic is modified in conditions with obesity. And so it is very important to say that the environment, the family, but also all the things that we are surrounded by are probably modifiers of our genome. So I don't know if I can go further or I wait for adding something.
I think you did a good introduction on really the disease. I think now we do understand from what you've been saying that we really have a more complete, I would say, understanding of the disease, that being a true chronic disease. And as you said, that is every day we have the immune system trying to fight the disease and everything. You did mention that we have some patients who are actually obese, looking, I would say, the same as other phenotype of obese patients, but that is coming from their genes. And then we have other type of disease. Maybe you want to do a real call on the MASH?
I would like to ask a question to Maite. Could you say that, like in diabetes, you see in diabetes, you say if you have one parent diabetic, you could have, the risk is 30% around, because the numbers are varying. And if you have two parents, it's more than 50%. Could we say now, because we have more than 50 years of obesity growing in the world, could you say that when you have one parent, direct parents, ascendant, obese, the chance will be the same or not?
I think that if you are one parent obese, your risk of being obese as adult will increase. And if we have two parents, it increase also. But what it has been shown, it's only that the impact of having parents with obesity, one or two, impacts the onset of obesity. So this impacts the early onset of obesity, not the obesity that started as in adults. So, and it is very interesting because adults may be more epigenetics, and childhood obesity can be more genetic causes.
Okay. And probably we could enhance about the MASH. This disease, brand new disease, because I remember 30 years ago, the steatosis hepatic was not so famous, and now it's. I heard that in France, around 20% of the people get the MASH, because the name changed now, because the last Congress they decide to say MASH. Okay, and the problem is that MASH is also like chronic inflammation, the mother of a lot of disease, because as you know, the liver is doing a lot of things for us, more than 200 transformations. And when your liver is fat, you don't know exactly what type of transformation will be impacted by NASH. So, and there is very few treatment for NASH today. The best one is to lose weight, of course, and to exercise, because you have to link the two. No diet without exercise, and no exercise without diet for the NASH. And I think that probably. Do you think there is also epigenetics influence on the NASH possibility in childhood, for example?
I don't have any data in mind to answer you with evidence scientific based, but it is probably the case. It is probably the case.
Okay. Okay.
Great. So maybe we can talk a little bit more about the management of the disease itself. Maybe Isabelle, you can walk us through how today we manage obesity, what are the treatments that are available and everything?
I think one of the probably most important approach to manage patients with obesity is to have a multidisciplinary approach, because it's a disease that it's not only an excess of fat, there are also, as we said, a mental component. There are also complications that you need to check for each patient. And also, we know that part of the management is linked to the diet and the lifestyles that you need to change, and also physical activity. But for that, you need some coaching or some regular interaction with the patients. And depending on what's happening with that, then you can lead to other therapeutic options. But it's important that the patient themselves understand that they have a chronic disease. They must consult doctors that are trained to treat or to manage that disease. It's not only a diet that you can see in some magazine or whatever. It's really a complex, and we spoke about inflammation, and you need to have that assessment, the full assessment of the patients, to take the appropriate management.
Yes, treating and curing obesity is very complicated because it's a multifactorial disease. You have inflammation, you have a complication linked to the weight, and also there is a very big impact on social behavior and social relationship. And especially, and I think that Maite will be okay with that, when it's a kid. Because when you are a kid and you're fat, it's honestly terrible. Because all the kids will harass you or will bully you, and that's terrible because they have complex after that. And I think that we need to integrate in the treatment of obesity also a psychological aspect and having specialists about this, because you could have after that kids that when they are growing they will be shut down, they will be very beside the society, and that's a problem. That's a problem. And you see, I have something very interesting because something that I'm used to tell. We are in countries where everything is normalized, even the way you open the door. You see what I mean? The lockers are like this, like that. And the quantity of sugar or fat that you could put in the candies for the kids are not regulated. That's crazy. I mean, we regulate everything. Everything. Your life is only regulation, and you have to cope and comply with regulation. But for the candies for the kids, no regulation, no cap, no limits. And I think that we have something to, because the war, the collective war, I'm calling that the collective war against obesity, is lost today. Lost, definitively lost. And we have to have, how can I say, a personal war and it's very difficult for parents, for example, because if you put food and exercise in the center of your education, you know that you will have problem with your kids, because you couldn't be only the people saying don't do this, don't eat that, don't do that. That's very complicated, and I think we don't have the very beginning of a solution today, except what Maite is doing at the CHU, because and you don't have thousands of Maite, so it's a problem. It's a real problem.
No, but I just want to mention that France has been structured since 2012 with the Center of Excellence for Managing Obesity, the CSO, because there was an understanding that there is something going on. It's not probably the answer for all, but I think it's already a step. There are 37 centers that are managing people with severe obesity. But where I completely agree with you is that we need to work also on prevention. Preventing, especially in the childhood, would help not enter those people entering this chronic disease. And we need to work on both sides.
That's quite interesting as a perspective, I think. Regulation, I think if you are talking to people in life sciences, they know what that means, so that's quite interesting. You did mention one word, you use one word, you use the word cure. And I think the question that I have for you, the follow-up question, I would say, are we talking about a cure for obesity nowadays, or are we more talking about diminishing the symptoms and then trying to manage the underlying causes that you mentioned earlier?
If you took a bariatric surgery, for example, you could say that you are curing obesity, because, as I could say to my patient, when you have a sleeve or a bypass or something like this, your body will change, but your brain is always a brain of obesity. So it's if you are not, you don't have some psychological surroundings, and you could fail, because your head, your brain, and you say it's the reward system, the frontal cortex, and the decision. In general, they will take the same decision after the surgery. That's a problem.
That's quite interesting. Maybe Igor? Yeah, Igor, you can take it.
I would like to address these last 2 points about, first of all, if obesity is a curable disease. In my humble opinion, the answer is yes, absolutely. If you will not eat for, I don't know, 3 weeks, your BMI will reduce and you will not be obese. But I would like to say a word about the regulation of the sugars and the fats in our food. Uh, this is, of course, something very good to do, but the question is if the restrictive approach will work. I think that it will be very hard to prevent from patients the joy, the enjoyment of eating something tasty.
Yeah, Igor, I'm okay with that. The problem is not to be too much restrictive, but at the end of the day, how many grams could you put of sugar, of saturated fat in a cookie? That could be interesting. It's exactly the same with the cars. When one day we say you don't have to go faster than 130 kilometers per hour, okay, you could say I would like to go to 160, but at the end of the day you couldn't be. And I think the restriction, we are living in a society where there is more and more people, so regulation will increase. And I just want to emphasize, I don't have the solution, but emphasize on one fact, that a lot of things on your life, day-to-day life, is normalized with regulation, not sugar and fat, and sugar especially. Sugar it's crazy. I mean, you could put as sugar as you want in anything. When you ask, you love, I'm sorry for English, the cornichon, for example. We have a pot of cornichon. Even in the water of the cornichon, you have sugar. I don't buy cornichon to have sweet taste. I buy cornichon, I love cornichon, for salted taste. You see what I mean? And they put sugar inside. So there is something around this.
Sugar.
And I think that we have to, I agree with Igor. You couldn't say no more sugar. That's crazy. It's impossible. Life is impossible without sugar. But you could also say that in the cookies, for example, you will put less sugar and less. We have done that for salt. In 2012, the government decided to work with industrial to reduce sugar and salt. Industrial have done the job. They were in the good way for that. But we have a lot of work to do to help those kids.
We are in a pickle. That's why we say.
Excusez, condition of pickle. I'm sorry.
Maybe Igor, you can help us also understand what are the innovative ways of handling the disease, because you have Regina and yourself have beautiful companies that are innovative in that field, and I think that would be interesting to have your voice on what are the innovative ways of handling obesity.
Yes, thanks you, Anne. There are a lot of startups dealing with obesity because, as the colleagues here said, this is very complex disease. But I think that something in common with these solutions that they are restrictive. They are reducing the amount of food, especially tasty food, consumed by the patients. And I think that it is very hard for patients to avoid from tasty food for a long time. So what Calitech is doing, we are developing a polymeric powder that is mixed with water and consumed as beverage before large meals. And when this beverage reaches the small intestine, it creates a protective layer on the small intestine walls that reduces significantly the absorption of fats and sugars. And in this way, we believe that we will be able to allow the patients to enjoy food from time to time, not on a daily basis to eat tons of sugars, but without paying the health-related price. Because we understand that people will eat sugar and fats no matter what we will do. If we will regulate the cookies, they will eat 3 cookies and not 1. The restrictive approach is problematic for these patients. And we think that solutions that will reduce the absorption of the food without reduce the quantity of food consumed by the patients may contribute something to these patients.
Okay. We have a very different approach. Our approach is that we discover that diabetics people and overweight and obese people have less sensors, captors, glucose captors in the matrix of the portal vein. As you know, everything that you are eating going to the intestine, and what you are eating is kept, is grabbed by the intestine, going in the blood, and all this blood is coming in the liver through a portal, the portal vein. Portal because in France, a port is a door. I mean, it's a door, the liver. So we discovered that the captors on the portal vein are linked with the arcus nucleus in the brain, where you have the propiomelaanocortin and NPY that are linked to accelerate or break the appetite. And we found a way to upregulate those captors with a device that we put on the portal vein. If the portal vein is there, it's around 10 centimeters and the diameter is 2 centimeters. We put on the portal vein the device, and the device recreate after we have made preclinical tests. After 8 weeks, the captors are upregulate, and there is a remission of type 2 diabetes, and they lose weight. So, of course, it's one solution. It's not the unique solution, because this solution, you need also a surgeon, because you have to put that with a cilioscopy. It takes around 15 minutes. But it could be a solution for people who are allergic to treatment, because GLP-1 are very good treatment, but sometimes people are obliged to quit because they have side effects, or they are allergic, or they couldn't afford the treatment. And with the Paltec device, you will be rid of diabetes from 3 to 5 years of remission. That could be a solution. It's not the best solution, but it's a good solution, because you recreate the circuit of regulation of the intake, the food intake, and the sugar intake.
You quickly mentioned GLP-1. Given that you are a clinician, maybe you can help us also understand how much of a breakthrough that was for your practice and your patient, and also, having the fact that we have Ozempic for diabetes and Wegovy for weight loss, just to make sure we understand the impact of those innovations. Okay,
GLP-1 is an incretin. It's an hormone secreted by the gut. 1% of the cells of your gut is secreting this GLP-1. GLP, say it's glucagon-like peptide 1. That's the name, GLP. Because I hate acronyms, because you don't understand anything at the end of the day. The GLP-1 is secreted by your intestine when sugar is coming. You don't have GLP-1 secretion when you don't have sugar. So the labs like Novo, like Eli Lilly, they create agonists of GLP-1, and they are very powerful because they are enhancing the secretion of insulin, and they also slow down the way of the gastric, je sais pas comment on dit la vidange, emptying. So there is two action. An action for increasing the metabolism of glucose, and also an action to lose weight. So you have liraglutide, semaglutide, exenatide also, and those treatments are very efficient. And so in my practice, I use semaglutide, liraglutide for diabetics people, and now you have a new compound called Wegovy, which is the semaglutide for the obese people, because we try to separate the obesity treatment from diabetes treatment, because it's quite different, and the way you are curing people is very different. So GLP-1 are very, very good solution. Now you have a new treatment with B-incretin, GLP-1 and GIP. It's a new molecule promoted by Eli Lilly, and increasing the weight loss, because you have a double action. And the problem with GLP-1 is that it's very complicated. You have to understand to separate the problem of the weight loss and the problem of diabetes. It's not exactly the same way to prescribe the product. And there is another treatment, inhibitors. I'm sorry for the acronym, inhibitor of SGLT2. I'm not familiar, dapagliflozin, empagliflozin. Very, very nice treatment because they are helping. In fact, they are provoking. They are your kidney is not retaining sugar, and you have sugar in your urines. Okay, sorry for my English. I have to switch sometimes.
Perfect.
And you lose a little weight, but is helping to regulate diabetes, and also they are protecting kidney and protecting also heart. Because these products came from the cardiologist at the very beginning, after the nephrologist, and at the end of diabetologist. But they are very good treatment, and the tolerance is excellent. So we have today treatment, and we have therapy that it's a revolution. I remember GLP-1 5 years ago. Very few people are talking about that. In Madrid, at the last Congress, everywhere you have a GLP-1. It's a big success. And it's a very beginning because it's a very good treatment. The problem is tolerance.
Maite, maybe you want to add something before we turn to the audience?
Yeah, and we also have setmelanotide, MC4R agonists, which are very promising, particularly in rare causes of obesity. And this treatment can also switch the brain, because I was so surprised when using GLP-1 agonists that they have also the possibility to change, not only the satiety, but the sensation of hunger. And that was not anticipated. We anticipate about satiety, but we did not anticipate that they can regulate also the hunger. So I think it's, as you say, it's a revolution. So of course, we need to do more, and we need to have other tools. But I think it's some kind of revolution.
I agree.
Do you have anything to complete the discussion?
Maybe? I would like to ask you, Maite, for the pro-melanocortin medicine in preparation. There is something, you see, in the hypothalamus, you have a place where you have the fact to be hungry or to be fulfilled between pro-melanocortin and also the NPY, neuropeptide Y. And do you have news about, because for the Prader-Willi, for example, Prader-Willi's syndrome of kids, they say that there is something in preparation working on pro-melanocortin, which is anorexic nucleus.
So I'm not aware on pro-melanocortin. I'm aware of the MCH, melanocortin hormone, but I'm not aware of POMC. For instance, MC4R now doesn't work on Prader-Willi syndrome. We thought that it could help a lot, but it didn't. So we have many things to learn.
Okay, thank you.
If we have any question, maybe we have 3 more minutes for questions.
I have a question for Igor. Igor, when your product will be available?
I hope in 3.5 years from now.
Okay. The same time for me. Okay, I could answer this question. The fact is that if you stop this treatment without having doing exercise, increase your muscle mass, change the way to eat and to, you will regain weight. If you're using the GLP-1 for obesity, of course, if you're diabetic, if you have type 2 diabetes, you have to it's very important. You must understand something. When you have a patient with, let's say, 7.5% of HbA1c, you see the 3 months of average glycemia. With those products, you are going to gain around 1 to 1.5% of HbA1c. I mean, it will be in the range where we will not have any complication for eyes, kidney, and something. And so you have to manage this treatment, because if one day you come back and say, I couldn't handle and could support the treatment, you have, as a diabetologist, you have a real problem, because the guys will come back to HbA1c at 7.5 or 8%, and that's a problem. So to answer your question, when you stop, and if you don't take any precaution, anything for dieting, for exercising, you will regain weight, of course, and you will regain probably also all the HbA1c that you lost. That's so it's a treatment. If you could handle it, you could have it for life. It's the same way for high blood pressure. High blood pressure is the same. When you have high blood pressure, the treatment is for life. I mean, so.
Merci. Do we have any other question? I think we're good. Thank you very much for your time. Thank you, everyone around the table.
Thank you.